I am an epidemiologist. I'm not a clinician. Until not too many years ago, I was not terribly interested in clinical questions. Most of my work focused on estimating the prevalence of mental disorders, risk factors for onset and course of illness that could be used to target interventions done by clinicians, but without me thinking a great deal about what those interventions were or how effective they were. But about a decade ago, I got involved in an epidemiological study funded by Dr. Insel here in the U.S. Army in the United States, studying patterns of suicide among people in the military. And the explicit goal of the study was not just to do descriptive analysis, but to try to give guidance to clinicians about what should be done. This is an enormous problem. Although the suicide rate is going down in most parts of the world, it's increasing in the United States, particularly among young people. Right now, there are about 20 suicides per day in the United States among veterans, military veterans. And the question is, what do we do about it? Well, when we first started doing these epidemiological studies, we found, somewhat to my surprise, that a substantial percentage, in many cases the majority, of the people who died by suicide had been in treatment for mental health problems. The vast majority, of course, had a history of psychopathology, as discovered by psychological autopsy studies after the fact, but the majority of these people were known to the treatment system. In most cases, they were not in treatment at the time of their death, but they had been in treatment, and in often cases were in treatment multiple times and failed. So the question is the treatment of mental disorders that bad that we can't prevent these people from dying who are in our hands? And as you know, doubtlessly better than I do, I came to learn after looking into the literature, treatments of mental disorders are in fact surprisingly good compared to treatments of diabetes and asthma and so forth. But there are a couple things that are distinct about treatments of mental disorders that have become the focus of my clinical epidemiological studies over the subsequent decade. And I came to realize that an epidemiological perspective is something that's missing from clinical research in a way that's very important. The problem is that there are many effective treatments for common mental disorders. If we break an arm, there's only one thing we can do. You go to the ER and you get your arm set. But if you have depression, you can go to a minister or a social worker or a licensed mental health professional or a primary care doctor who gives you an antidepressant medication, or you can go to various kinds of complicated psychotherapies or combinations, or nowadays infusions, ketamine and so forth. But none of those things is optimal for all patients. There are a number of studies that show that if you take one of the evidence-based treatments and randomly assign it to a patient for depression, say about 30% their episode will remit. And we know from the STAR-D study and other studies that have been done subsequently, if you take those people who don't remit and take another one at random and give it to them, about 25% will remit. And if you take a third one at random and give it to another, maybe 15 to 20% will remit. And if we can keep people in treatment long enough, it might be that we get over 80, 85% remission. The problem is that depressed people are depressed and they give up on treatment. And we found in the military that the typical pattern is they go into treatment and they drop out. And then 6 months later they come in for another kind of treatment and they drop out. And a year later they come into treatment, and after 2 sessions they're not doing well and they say the hell with it and they kill themselves. So we started thinking that really we have this, if we had kept those people in treatment for the 4th and 5th and 6th treatment, in the vast majority of cases we would have been able to do something with them. But we don't have that many chances. We have to figure out how to get the right treatments to the right patients right away. And we're not currently very good at that. Not much is known about how to match the right treatments to the right medication, to the right patients. And as a result of that, in many areas of medicine, it's psychiatry, trial and error, often informed with some understanding of pharmacodynamics and pharmacokinetics, or clinical comfort with a particular medication used over the years governs treatment selection decisions. And that's especially true with incident cases, as opposed to people where this is the 5th episode of schizophrenia and you know they responded to Seroquel the last time and you give them Seroquel again. What do you do with that first episode? Very little is known. It's likely, as I said, that the vast majority could be helped if we could stick with the treatment through to the trial thing, but it often fails to happen. And sometimes failure to stick with treatment has tragic consequences. As a little interesting aside, I wasn't thinking of speaking about this, but I just was telling someone about this last night. In the World Mental Health Surveys, which I run, we ask people who have a history of a particular disorder, think of major depression again, how old were you when it started, your first episode? Have you ever gotten treatment? Have you ever seen a professional? And it turns out that in most developed countries, the vast majority have 60, 70% have seen a professional sometime in their life. And then we say to them, have you ever seen a professional who really helped you? And about half of them have. And then we ask another question. For the people who've seen a professional who helped them, we said, how many different professionals did you have to go to till you found one who helped you? And the people who didn't get helped from the professional they saw, well, how many did you try? And it turns out that you can estimate survival curves. You can say, what's the conditional probability of being helped the first time? And for the case of depression, it's about 30%. If you're not helped the first time, what's the cumulative probability of being helped the second time if you go a second time? And a third and a fourth and a fifth. And it turns out that if we want to get people up to the point where 90% are helped, in virtually all developed countries in the world that we've studied 23 of them now, you have to go to 5 people. 5 people you have to go till you get. The question is, among the people who are not helped the first time, what percent go to a second person? Of the people who are not helped the second time, what percent persist and go to a third and a fourth and a fifth and so forth? It turns out that the reason that there's the discrepancy between the 50% who are helped and the 90% who could be helped is because people quit. People give up. And we started looking at predictors, epidemiological predictors of what are the predictors of being helpful and getting helpful treatment. And we found an interesting thing, that there is a significant association between time and helpfulness of treatment. People who started their treatment after the introduction of SSRIs are much more likely to have been helped than people who started treatment when they got a TCA or an MAO. All else equal. But there is not an association, and that's the helpfulness of treatment if you get it. In other words, if you get the first treatment, it's significantly more likely to be helpful if you got it after 1987 or so. If you get a second treatment, it's significantly more likely to be helpful if you get it after 19 than before, and so forth. However, there's no association between time and whether at the patient level the patient says they were helped. Why is that? Because in recent years, younger people are giving up quicker. So the older you are, the less helpful treatment was when you tried it. But the more likely you are to persist. And as a result, the percent of people who were helped nowadays is 50%. The percent of people who were helped 20 years ago was 50%. And in our little Lancet Commission, Mario, where we're talking about why is it that as treatment has gone up, prevalence of depression has not gone up? That's why. People try 1 time or 2 times and then they give up. And the typical question is, have you ever gotten treatment? It's not whether you persisted in treatment, whether you went through the whole course. Going through the whole course is critical. Now, one way of resolving that is to try to make the treatment selection process a process more evidence-based, picking the right treatment for the right person. Now, precision medicine, which is for biological psychiatrists, you know what precision medicine is. There's an enormous amount of research that's been carried out to find reliable prescriptive predictors of differential treatment response. By the word prescriptive, in this literature, we mean a predictor that says that treatment A is going to work better than treatment B for this particular individual. We have a lot of information about that. Psychiatrists have focused largely on biomarkers, but so far without a great deal of success. There's some interesting stuff about neuroimaging, and there's these people doing things with pharmacogenomic tests, but they're not really ready for prime time yet. And there's new stuff that's going to be done with ketamine, who are the people who are most likely to respond to it, and so forth. But not a great deal in terms of clinical usefulness. Psychologists have focused largely on clinical ratings and patient self-reports and performance-based neurocognitive tests, and actually have had considerably better results. But psychological studies are typically very small. They're not funded by pharmaceutical companies. There's very little replication and so forth. What we need to do to move forward in this line of work is 4 things. And I'm going to talk about those 4 today and describe to you several projects I'm involved in that are doing these things. And I think this is the way forward. The first is we need comprehensive predictor sets. When we do research, so much of the work, particularly the work on biomarkers, is interested in one particular hypothesis or one set of biomarkers, the genomic kind of test or the fMRI test or what have you. But looking at really a comprehensive set of all the kinds of predictors that are important. And that means very long baseline assessments. Second, we need comprehensive comparisons across the full range of available treatments. Typical studies in the precision treatment world are looking at 2 treatments. Clinically, you have many more than 2 treatments. We have to start looking, and network meta-analysis doesn't help us with this because we're looking at the individual level. For that particular individual, what's the right treatment? And so you can't do meta-analysis. There are other ways of doing meta-syntheses of individual level data, but not what we have right now. And the third thing, and I'll say more about this in a little while because it has profound implications for how we do these studies, we need much, much bigger sample sizes. The EMBARK study, for example, 300 and some people, 3 arms, 2 phases, there's 80 people, it's hopeless. It's just hopelessly underpowered. And that's the case with many of these studies. There's often the idea that this is a preliminary study, we're going to be able to find things and then we can replicate it in another study. That doesn't work because if you only have 80 people for arms, you're not going to be able to see the signal. And there's nothing to replicate. You're just going to be replicating a bunch of noise. We need much, much bigger samples. And the question is, how do we have designs that makes that feasible? And as you'll see in a moment, my sense is that clinical trials are not the way to go. And then finally, we need to have improved statistical methods to develop optimal precision step care systems. And there's a great deal of progress being made in that area, although there's a lot of focus on can we do something there. That's really a problem that's pretty much solved at this point. It's the more practical, kind of low-level problems that we have to deal with. I'm going to say a little bit about each of these things. Now, comprehensive predictor sets. We already know about quite a few consistently significant predictors, as I mentioned. But they've never been included together in a single prescriptive model. So we finished an analysis recently of looking at all the replicated predictors of differential response, just the broadly defined antidepressants alone, psychotherapy alone combined. Very broad kind of thing. There are about 35 predictors that have been replicated as being significant predictors. But there's never been a study that's looked at all 35 of them at the same time. And the best we have are studies that looked at 15 of them at the same time, with about a sample that was about 20% as big as it needed to be able to do anything. So we really don't have much of anything. We need to know potentially important predictors we need to be considered. They include, in naturalistic studies, which is where I'm going to be going in a minute, using natural language processing of clinical notes, texts, Facebook posts, and so forth to learn more than we do right now about things that are important. Small area geocode variables. So, for example, in my work on suicide, one of the strongest predictors of whether a veteran, a military veteran in the United States, will kill themselves is the unemployment rate in their local labor market, which is not something we look at typically. And that's true even among people who are hospitalized for a suicide attempt. Here's a person who's made a suicide attempt. They're in a hospital. Are they going to kill themselves in the 3 months after discharge? One of the strongest predictors is, do they live in a place where there's a high unemployment rate? Something we never look at, but it's readily available. And there are also a lot of promising and scalable targeted biomarkers that we can look at. And I should mention here, although it's something that's a little more complex than we can talk about today, that a lot of what I call about scalable biomarkers, a lot of biomarkers are expensive to collect, either in terms of the cost of the procedure itself or the time costs of collecting the data and shipping the data and processing and so forth. There are many cases where there's no need to test the biomarker. So in other words, we can, with a series of relatively inexpensive tests of self-report measures right now, say that some very inexpensive ECBT, PTSD coach, one of these things that's sort of an app kind of thing, we can say with great assurance that that's going to work well for that patient. We shouldn't be doing a $350 pharmacogenomic test on that person. We already know an inexpensive treatment is going to work. And we also know that there are certain characteristics that say that the things we have right now are not going to work for that person. We can narrow the people who we give the expensive biomarker test to by tiered kinds of thoughtful modeling procedures, which is something we don't do. But again, given the enormous costs of doing the biological studies, that's something we have to do. Improved statistical methods. The broad logic of estimating prescription prediction models is pretty clear. It's things that you all learned in the first statistics course. We have treatment A and treatment B. So we have an active comparator. Does the person remit? And we have a variable like gender. Are they male or female? And we have an interaction between the two things. And if the interaction is significant, gender is a prescriptive predictor. So we know, for example, that women do better than men with interpersonal psychotherapy, and men do better than women with cognitive behavior therapy. Men do better with cognitive behavior therapy, and my deep clinical insights about this, because men don't really want to talk about it. They just want somebody to tell them the rule, and they will do it. Women, on the other hand, do not want a rule. They want to talk about it. So there's, sort of, it's probably a little bit more complicated than that, but as I said, I'm an epidemiologist, I'm not a clinician. But the idea is you find that when you assign at random two kinds of psychotherapy to people, men and women, you have an interaction. The interaction is always significant in that direction. So if gender was the only thing we knew, it would be easy if those were the only two treatments we have. We would give IPT to all women and CBT to all men. But it's not that simple, because there are other things. There are aspects of personality that interact just with those two kinds of treatments. There are family history, symptom profiles. One of the things I found that is, again, in a sort of a deep clinical insight that I discovered in a number of studies, which is really, and particularly in one I'm involved in right now, one of the strongest predictors of medication working, psychotropic medication, is whether the patient takes the medication. And we can't know whether that's going to be the case until after we try it. However, there is a great deal of interest in the literature on treatment adherence, and there are scales that exist that can be administered to people in 2 or 3 minutes before treatment starts that turn out to be very big predictors. And we're doing a study in the Veterans Administration right now where we've administered the scale, and we can just on the basis of that one little 2-minute scale say either that this person should not be getting antidepressants alone, or they need some kind of case management to hold their hand to make sure they take it. All by itself, just that one little 2-minute thing. And in fact, in typical routine care, that's not used, but it could make an enormous difference. I said before that 30% of people do well just at random in one treatment and maybe 50% in two. The difference between just, are you somebody who's going to adhere or not adhere to your medication? It turns out that's the difference between a 40% and a 20% treatment response rate. I mean, it's not rocket science. It's just sort of kind of common sense, and it's surprising to me as an outsider coming into the clinical world. There's a lot of deep thinking, but there's often an absence of common sense. But the thing is, when you do these kind of models, you typically find 10 or 15 different variables that have significant interactions with treatment A versus treatment B. And it gets more complicated when it's treatment A, B, C, and D. The question is, how do you put all those together into one composite model that says, for this particular patient who's a female with a certain IQ, with a certain personality, with some history, okay, what do I do for that person? Weighing all those things together. And there are optimization techniques, but they're very seldom used. The best algorithm, the best way to come up with those things has to do with the fact that we often don't know that there are the 15 significant predictors to begin with. The literature has said there's 30 that work sometimes here and sometimes there. We don't know which one is best. We want to put all 30 in, but maybe only 15 will turn out to be significant. And we don't know which 15, so we have to worry about overfitting and feature selection. We have to worry about the fact that typically the models that are looked at assume some linear association between some personality characteristic and an additive interaction. It might not be that. It might be a very high-order interaction. There's some complicated neural networks needed to capture. And of course, there can be non-additivities as well. So the best way of dealing with this problem in terms of statistics is to work with a machine learning algorithm. And a number of you, I'm sure, are familiar with machine learning algorithms that exist for these purposes. But as with therapies for treatment of mental disorders, there's no one machine learning algorithm that's optimal for all situations. So you very often find papers where people try 2 or 3 or 4 different ways of doing it and decide that this is the best one. If you go to R or Python, which are these collections of computer programs, there's currently close to 100 different machine learning algorithms out there. 100 different ones. And nobody tries all 100 of them. They try 3 or 4 that they're familiar with or something that sounds interesting. But there's really not much in the way of systematic ways of dealing with this. But there are, as I mentioned a little while ago, this is now becoming pretty simple because there's ensemble machine learning methods, and I won't go into any detail about this other than to mention there's something called ensemble machine learning methods, which is that you can use a whole bunch, because computers are so big now, we can take a whole bunch of these different algorithms, run them in parallel, carry out simulations, come up with weighted averages, and determine an optimal way of combining all this information. There's also a way of doing this with deep learning, with multi-level neural networks, although that has some problems of overfitting. So the statistical methods part is not really a big issue anymore. We know how to do this, although in psychiatry, it's sort of disappointing that when you see papers doing machine learning, they're still not doing optimal things, but the optimality there exists. The real problem is this simple thing of sample size that I mentioned. Precision treatment models, as I mentioned a minute ago, are at their heart multivariate models with a focus on pooling across multiple significant interactions. And power to detect interactions, as you know, statistical power is lower than to detect main effects. And that's especially the case when we're looking at composite predictors based on multiple interactions, especially when preliminary searches are needed to detect meaningful nonlinearities among marginal effects. Big samples are needed. Simulations have been done, and we found that precision treatment studies in psychiatry in particular are just hopelessly underpowered. Even for something as simple as having treatment A and treatment B, and is the patient going to remit from a major depressive episode where you could expect 30 to 50% remission rates. The minimum number of cases we need per arm is 300. The minimum. Probably 500 is safer for a realistic model. 2-arm clinical trials of just sort of a one-phase depression treatment with 1,000 patients, they don't exist. STAR-D didn't even have that big a thing. They had 4,000 in total, but they didn't have that in their first 2 original arms. Much larger samples are needed for more complex trials and less common outcomes. So some of the work I'm doing on suicide, for example, I'll talk about in just a few moments, we're looking at over 50,000 patients who are treated in various ways. Now, large trials of this sort exist to evaluate common decisions in cardiology and in oncology. The CARDIA study you might have heard of. Middle-aged men with mildly elevated cholesterol who were randomized and followed for 10 years, 350,000 men. A trial with 350,000 people. We don't have studies like that in psychiatry. How come? Well, the governing bodies that decide how much money to put into what disorder are largely made up of middle-aged, slightly overweight men with high cholesterol, and they're pretty interested in cardiovascular. They're not interested in depression all that much. I think it's unrealistic to think that we're ever going to get enough funding to carry out such trials, to study the many decisions needed to optimize treatment of mental disorders, and we have many more decisions to make. The CARDIA trial was really just, where do you start the statin? Is it at 180 total cholesterol, 160, 210? You know, I mean, it's just a simple little thing. It's not anything anywhere near as complex as what we have in psychiatry. So as a result of this, I think the only hope is the comparative effectiveness research based on observational designs with embedded pragmatic trials is much more realistic. Now, I don't know how many of you are familiar with this, but there was a Cochrane review a couple of years ago that showed that when you take well carried out comparative effectiveness studies, observational studies, that risk adjust for differences across patients in observational data between treatment A and treatment B, because they're not at random, and you adjust for loss to follow-up using something called double robust methods. The results are surprisingly similar to the results of controlled clinical trials at a fraction of the cost. So the question is, can we use the same kind of design here? And the answer is yes. There are 4 challenges in doing that, though. One is we have to get the measures of the prescriptive predictors, and I'm thinking now of clinical studies in observational data sets, and I'll jump forward and talk about that in a minute. The other is balancing on baseline covariates, that people are not randomized to treatments. There's sometimes that certain people always will get treated in a certain way, and there's no way we can look at the effect of differences in treatment for those people. It's got to be people who are close to equipoise. The third is we have to measure relevant outcomes in the absence of measurement-based care, which we don't have in psychiatry. So how do we know that treatment works? And in many cases, as you know, you don't. The patient seems to be doing well, you discharge them, they're gone. You have no clue what's going on 6 months later. Because mental disorders, other than in psychiatry and bipolar disorder, are treated incorrectly as if they're acute conditions rather than chronic recurrent conditions. So we don't have a lot of information about long-term effects. And then we have to deal with loss to follow-up because of that. We don't have those data. Now, let me tell you about 3 studies I'm involved in very quickly that are addressing these challenges. One is a study I'm working on with some colleagues at West Virginia University, one of the poorest, most rural states in the United States, the highest opioid death rate in the United States, highest suicide rate east of the Mississippi. And most of the people live in these very small rural communities where healthcare is delivered in a network of close to 100 small clinics. And when I say small, I mean some of these clinics are so small there's not a physician there. There's a nurse there Monday through Friday, and Monday, Wednesday, and Friday morning a physician comes, or on Tuesday and Thursday afternoon a physician comes. That's how small they are. They don't have mental health treatment, but they have very high rates of depression, very high rates of anxiety disorder, a lot of substance disorder, and it's all treated pharmacologically by the primary care doctor. Very little telepsychiatry because it's such a poor state. So we are, with the help of Pim and some others, looking to see what's the effect of adding on an adjunctive internet-based cognitive behavioral therapy to the antidepressant treatment for these people. It's a very large trial because of things I mentioned. 6,000 people. We're studying 6,000 people in treatment for depression, 2,000 treatment as usual, 2,000 getting a light version of internet psychotherapy, and another one sort of a more intensive version with case management. It's expensive by our standards, $15 million, but it's nothing like the Cardia study. It's not like, $300 million. But it's something that at the end of the day, our hope is that we're going to be able, by having a rich baseline assessment of all the things that have been found in the literature to predict differential response to ECBT as an adjunct to pharmacotherapy, be able to tell the primary care doctors, based on a relatively simple series of questions we can ask patients at the beginning, which patient should get it and which patient shouldn't get this as an adjunct. Just a first step, but it's something that's extraordinarily practical and very inexpensive. A second one, which is a little different because it doesn't have to do with us collecting data. In the first study, we have a big baseline survey, and then we follow people 3 and 6 and 12 months later with surveys again, assessing their depression, looking at claims data. In this second study, the decision whether to hospitalize patients is all based on claims data, and this is the one that I said is so large. The Veterans Administration in the United States hospitalizes 100,000 people a year for a psychiatric problem. That's 1% of all VA patients. They account for 12% of all suicides in the next 12 months. Most of them in the 3 months after discharge. The decision whether to hospitalize is made for a variety of reasons after a suicide attempt, and it's not always having to do with the patient. So when a patient makes a non-fatal suicide attempt, if they're in Madison, Wisconsin, which is a very rural VA, they immediately get hospitalized because there's 15 empty beds there, and they just immediately put people in the hospital. In Los Angeles, on the other hand, it's tough to find a bed. So if you're married and your wife can come and get you, you won't be hospitalized. There's all kinds of considerations that determine whether you get hospitalized. Now, interestingly, doing standard comparative effectiveness research, we look at what's the effect of being hospitalized after a suicide attempt on a person doing well afterwards. And what we know about doing well is, did the person die in the next 12 months? Were they hospitalized again? Did they make another suicide attempt? And among the people risk-adjusted who were not hospitalized after a suicide attempt, 15% of those people within 12 months are dead, or they've been rehospitalized, or they made a suicide attempt. Sometimes they're dead from suicide, sometimes they're dead from an accident. The rate of accidental deaths among those people is 5 times higher than the rest of the population. So probably they weren't all accidents. But the idea is that that's a very high rate. 15%. What happens when they're hospitalized? 15%. Makes absolutely no difference to the outcome whether they're hospitalized or not. Now, does that mean that hospitalization doesn't work? It's impossible. We all know cases that if that person wasn't hospitalized, he'll be dead tomorrow. So we know that hospitalization works in some cases. However, there's a lot of thinking. The dialectical behavioral therapy people, for example, are very opposed to hospitalization. That in some cases, hospitalizing a person in the wake of a suicide attempt can actually hurt them. And the thinking is that's why the suicide rate is so extremely high. The 7 days after discharge from the hospital, the suicide skyrockets. People are just waiting to be released and they kill themselves. Our thinking is that there are probably some people who are helped by hospitalization, others who are hurt by hospitalization. And if we could figure out who those people are by looking at characteristics of the patient, characteristics of the community treatment setting in which they're embedded, we could, instead of having that 15% rate of death within 12 months later, if we could reduce it to 12, that would be doing an enormous amount of good. Remember, there's 20 suicides a day among veterans. If we can make it 15, that's a big success. So we're doing the same kind of study there, using natural language processing of clinical notes to find out things about the patient. We're not interviewing any patients. We're just taking claims data and seeing what we can abstract from the existing data to predict differential treatment response. If we're successful, then we're going to have a pragmatic trial in the VA where we go to certain sites where we put this in place and we can see, can we save lives? And if we're successful there, then the next year we'll go to Tom and ask him about having Mindstrong. We'll put it out. Well, those people will track in a different way to see are there ways that we can get more subtle kind of signs that we can get right now. The last one, and then I'll stop, is some work I'm doing with colleagues in Taiwan that I'm really interested about. The country of Taiwan, or the renegade province of Taiwan, if you will, they have, in the past decade, have had about 30,000 episodes of first-onset schizophrenia. I know very little about schizophrenia, but it's an interesting model. They have 15 different medications they prescribe to people as their first medication, and they don't have the help of the fact that they have a history of medication response before. It's just the first medication. And so we've developed these precision treatment models using the methods I described to you vaguely here, taking all the information we have from their consolidated files. We have family history data, so we know whether their father was an alcoholic and their mother had some bipolar diathesis, whether there's any other schizophrenia in the family, what they had before, and so forth. And the outcome we're looking at is the outcome that's there in the records, which is, could we keep them out of the hospital for 12 months after the first onset? After we treat them, stabilize them, and put them out in the community, could we keep them in the community doing okay for 12 months? Only 40% of patients are able to stay out of the hospital for 1 year. So we found that by developing a precision treatment rule and doing a simulation, it looks like we could keep 55% out of the hospital within 1 year, for up to a 20% increase in treatment success. Now, this was based on a relatively scant set of predictors. We're now going back and redoing the analysis, looking at some more in-depth stuff we didn't have body mass index, for example, which is an obvious thing for certain kind of medications you wouldn't want to use. But if it turns out that on the replication we show that we have the same kind of success we had there, then the country of Taiwan, starting next year, is going to implement this in half of the country. Half of the 28 million people in the country, we're going to have this precision treatment rule available to clinicians to decide how do you optimize incident medication prescribing. It's not something that's going to be a requirement, but it's going to be an adjunct, a clinical decision point support to the clinician to see whether, again, we can keep people healthy better. And these are just some examples of things that I think are going to become increasingly common in the literature as we move forward, if we're going to start rationalizing how treatment in psychiatry works. We need to do better measurement-based care. We have to do evidence-based care. We have to follow our noses and do things in a systematic, continuous quality improvement way. Now, computers, of course, don't know everything that clinicians know. And we don't want to say there's some clinicians who sort of object to this. I'm not going to have a computer telling me I'm the clinician. That's true. However, it is important to realize that patients often are willing to tell things to computers that they don't tell to people, or computers can pick up things incidentally that you can't get people to say out loud. And computers are much better than humans are at putting things together, particularly when the computers work in consort with intelligent clinicians. You know, when Gary Kasparov was beaten by the IBM computer in chess, it wasn't a computer that beat him. It was a computer and 10 international chess masters that together thought through moves, and at the very end, the computer simulated the end game. But the human beings had a lot of the input into that computer program. So it's not just a computer by itself, it's the computer interacting with the thoughtful humans that makes the best decisions. That's where we have to go. And these are just simple examples of the first stages of those, but I think they're examples that you're going to see increasingly in the years forward, and I hope you will get involved in doing them, because we from the epidemiology community look forward to collaborating with you clinical folks in this. So I thank you very much.